button. Good afternoon, everyone, and welcome to this very special event. This is on behalf of the Dialogue Institute at Temple University in Philadelphia, the United States. I'd like to welcome you to a Zoom panel discussion that is titled Religion and Medicine, a Dialogue with Healthcare Providers on Navigating Religious Diversity. So this afternoon, we have some really delightful guests, some experts from around the region and around the country that will be contributing to a really fascinating discussion, I think, about the role that dialogue and religious literacy plays in providing healthcare in communities. So if you don't mind, I'd like to share just a little bit of an introduction to the Dialogue Institute in case this is an organization that is new to you. The mission of the Dialogue Institute is the Dialogue Institute engages religious, civic, and academic leaders in practicing the skills of respectful dialogue and critical thinking, building and sustaining transformative relationships across lines of religion and culture. It provides resources and creates networks for intra and inter-religious scholarship and action that value difference and foster human dignity. Established in 1964, the peer-reviewed Journal of Ecumenical Studies advances critical awareness of the latest directions in ecumenical and interreligious research. And of course, our Journal of Ecumenical Studies is open for submissions and also open for book reviewers if you are so inclined. So be sure to visit our website when you get a chance to learn a bit more about our programming. Some of the highlight programs that we run include our study of the U.S. Institutes on Religious Pluralism. This is a program that runs in collaboration and with the support of U.S. State Department funding, where we host international groups from around the world, both young adults and older adults, in programs that teach literacy and understanding of religious difference, discuss the origins of democracy in the United States, and teach the skills of dialogue and leadership to be applied in home settings. We also have a new program over the past year in partnership with Citizen Diplomacy International, where we train young innovators in social innovation and STEM innovation, and training them and equipping them with the skills of dialogue and cross-cultural understanding and communication. We also are running a tours program highlighting religious diversity and pluralism in the city of Philadelphia and beyond. And you can sign up if you want to take a virtual or in-person tour on the streets of Philadelphia and beyond. Lastly, we also have a new program that facilitates dialogue and understanding between African Americans and Jews in Philadelphia. And we have a partnership with a documentary film, and we're looking to expand our programming in these areas as well. So we're excited today because this is a program that really gets to the core of the work that we do, advancing understanding across religious difference, helping people to be equipped to understand and to work across difference. And number two, to be focusing on the skills of dialogue. How can we apply dialogue to everyday life? So without further ado, I'm going to turn it to a recent Temple University Department of Religion graduate, Heidi Isaac, who will assist us with some conceptual framing and set a foundation for our conversation today. Heidi?
Thank you, Dave. Sorry, one moment. I would like to just say a few words before our panelists get started sharing their experiences. So personally, I know that medicine was developed through the study of religion, yet I have encountered numerous individuals who do not know the connection and importance of having a religious studies background in the medical field. So I'd like to say a few words about that. In the 5th century BCE, Hippocrates, often remembered as the father of modern medicine, recognized the body's natural ability to heal itself. He even instructed physicians to find blockage within patients and between them and the cosmos when attempting to heal them. Hippocrates' formal name was Hippocrates Asclepius, which literally meant the descendant of the doctor god Asclepios in Greek. Before Hippocrates, people believed that the gods caused human diseases. Through Hippocrates' practices and teachings, which are recorded in the oldest medical books we have, which contain more than 60 books collectively known as the Hippocratic corpus, the belief that natural forces cause diseases became the new popular belief. The Hippocratic corpus, which was completed roughly 100 years after Hippocrates' death by many different physicians during his time that are believed to say the same basic assumptions Hippocrates has had about the human body, how it works, and the nature of diseases. The medical practices found in the corpus led to the creation of the Hippocratic Oath. The Hippocratic Oath, as many know it today, is a document on medical practices, ethics, and morals. However, the oath that medical graduates took today at the start of their career is not the original one of the 5th century BCE. The original oath starts off by mentioning 4 Greek gods, yet today it may seem that religion is removed from medicine altogether. In fact, physicians are told not to let their own religious views affect how they practice medicine. Physicians are supposed to not let their religious views control their decisions, yet it is not uncommon for a patient to choose the medical practices that best agree with their religion. Therefore, we here at the Dialogue Institute strongly believe that having knowledge of religious pluralism would be highly beneficial in the medical field, that it would lead to better care for the patients and their families, ensure all the needs of a patient are met, avoid any unnecessary added stress to the patient and their family, and even reduce the number of lawsuits against physicians and hospitals. 2 years ago, our editor-in-chief of the Journal of the Ecumenical Studies, Dr. Terry Ray, and his late wife, Maria Ray, a former medical interpreter at CHOP, wrote an editorial for our 54.3 issue. In it, they each provide a personal case study where religious illiteracy had detrimental outcomes for the patients and the hospitals involved. They make the case that training in religious literacy should be provided to all healthcare providers, especially in a large ethnically and religiously diverse country like the United States. The United States attracts patients and families from every other continent, each coming with their own set of religious beliefs and practices. Ray and Ray discussed the consequences that arise from misunderstanding such beliefs and practices, and call for hospital professionals to be conversant with the religious-based values of the traditions that they are most likely to encounter on any given day. And that is a direct quote from their editorial. You could read their article in full in our summer 2019 issue, but now we will turn things over to our honored panelists who will be sharing their experiences regarding the following few questions. We know that in the past, religious and moral narratives informed our understandings of illness and disease. Does this still hold true today? What are some of the challenges that healthcare providers face in practicing medicine in a multi-religious, multicultural environment? And lastly, have there been instances where your patient's religious views have restricted or influenced how you have provided care to them? First, we will hear from Dr. Devin Stahl, an assistant professor of religion and bioethics at Baylor University. Dr. Stahl has taught bioethics to undergraduates, medical students, nursing students, veterinary students, and medical residents. She also worked as a hospital chaplain and a clinical ethicist in hospitals. Her interests include medicine, theological bioethics, disability studies, and end-of-life issues. Next, we have Dr. Renee Hamdea Fanal, the president of Dental First Corporation, and she is also involved with the Temple University Kornberg School of Dentistry's Diversity Office. Dr. Fanal was a registered nurse before she started practicing dental medicine and has used both trainings to educate the community about the connection between oral and systemic health. She is working on a book titled Oral Health, The Gateway to a Healthy Heart. Our last panelist for today will be Dr. Bijan Edmod, a clinical associate professor of psychiatry at the University of Pennsylvania, as well as a practicing psychiatrist himself. When it comes to patient care, Dr. Edmod has the most experience among our guests this afternoon with over 60 years of it. Dr. Stahl, would you like to start off?
Yeah, hello, everyone. Thanks for having me. So I'll keep these remarks brief so we can get into lots of good question and answer. So when we think about the landscape of religion and medicine, it's easy to think now that there's an easy separation between the two. The medical sciences rely on fact and religion relies on belief. But of course, it's not that simple. A lot of my research is on how theological ideas influenced medical practice in earlier centuries, as Heidi was just saying, particularly in the West. So there's no question that for most of recorded history, there was a strong alliance between medicine and religion. Natural philosophers, who today we'd call scientists, were concerned with discovering who God was through learning more about the human body and the natural world. These physician philosophers were considered secular theologians, meaning they thought about theology not as ministers of the church, but as people who taught and thought about the natural world. In fact, against the myth that religion and science have always been opposing discourses, it was religious belief in God that God could be known through studying the natural world that fueled the scientific revolution of the modern era. Now, since that time, medicine has really pulled away from its reliance on theology and any particular understanding of God. So the scientific method itself doesn't necessarily rely on theological premises. However, in many parts of the world, including in this country, we still have a significant number of people who consider themselves religious. Their understanding of illness is shaped by their religion, and their engagement with medicine is also influenced by their religious beliefs. Now, study after study shows that people make medical decisions based upon their religious beliefs. Now, sometimes this is obvious, like when a Jehovah's Witness refuses a blood transfusion, or when a Christian Scientist believes that prayer alone will cure their disease. When I was a chaplain, it wasn't uncommon for patients to ask me to pray that they would receive a miraculous cure, or that God would guide their physicians to effect a cure. But beliefs can act more subtly too, influencing people's trust in medicine or their physicians, the spiritual distress they may experience as a result of illness, or the coping mechanisms they use to get them through illness. Religion remains pervasive in the patient imagination, as well as for some of our medical professionals. The diversity of religious belief in our country presents particular challenges for clinicians, however. I fear that many of our clinicians are not trained to have religious conversations. Even if a clinician is themselves religious, this doesn't necessarily mean they have a basic understanding of the various religious beliefs of their patients. And of course, we wouldn't expect them to. I have a graduate degree in religion, and I don't understand everything about every religion. In fact, I fear that we're equipping many of our clinicians with just enough knowledge to be dangerous. In other words, we teach them a little bit about different religious worldviews, and then they assume to know much more than they do. Or they forget that belonging to a religion doesn't necessarily mean that a patient adheres to every aspect of their tradition's beliefs. Instead, I think we should be teaching our clinicians how to ask the right kinds of questions of patients and to not be afraid when patients present them with very particular religious answers and explanations to their beliefs. We don't want to debate theology with our patients, but we also don't want religious belief to be a conversation stopper, and this can be a delicate balance. So as a clinical ethicist, I've seen it happen many times where a physician became quite frustrated with a patient when their religious beliefs seemed to be driving them to reject medical care or to request aggressive medical care. I remember a time when a young mother refused a blood transfusion, knowing that she would likely die without it. Now, this created incredible distress on the medical team, who worried that her religious beliefs were coerced and had a hard time accepting that anyone in their right mind would refuse something as simple as a blood transfusion. And once it was established that the woman did have decision-making capacity and that her decision wasn't coerced, she was allowed to refuse that transfusion, and she did die. Now, after that, there was a lot of debriefing that needed to happen with the medical team so they could better understand her decisions and express their feelings about it. I've also witnessed and done research on requests for non-beneficial treatment at the end of life in the hopes that a person would receive a miracle. Now, this can be an incredibly frustrating experience for many clinicians because they aren't sure how to talk about religion with these patients, and they feel as though they're going against their professional obligations of beneficence and non-maleficence to provide treatment that's non-beneficial. Now, this is where I think training on how to talk with patients about their religious beliefs can be incredibly beneficial. Many patients want to talk about their beliefs with their physicians, but many physicians don't feel equipped to have these conversations. Now, this is where chaplains and ethicists can be tremendously helpful. In many instances, I'll bring in religious leaders into family meetings to help guide these conversations, which is not something we would normally do. Now, of course, not every patient will want that, but if religion and religious authority is important to a patient and is helping to direct their medical choices, then this is something the medical care team should take seriously. I don't think that we need to provide any and all medical treatment that a patient requests simply because they say the request is based on their religious belief, but attending to those beliefs can establish trust and respect with patients and may be necessary if we want to find mutually agreeable treatment plans with our patients. Now, all that to say, I think we have a long way to go in training our medical professionals to understand, respect, and converse with patients who hold religious beliefs that they themselves don't hold. So given the diversity of religious traditions in this country, that's no small task. So I hope we can chip away at that a little bit this afternoon. Thank you.
Thank you, Dr. Stahl. Dr. Fanal?
Greetings, everybody. I am going to echo Dr. Stahl, and I'm going to come from a position of unconscious bias. And from that position of unconscious bias, I am echoing her to say that it starts in the medical schools, the dental schools, the nursing schools, the pharmacy schools. And everyone, we all have unconscious bias. We actually don't know that we actually have it, but it does rear its head many times. So the real question is, are you aware or are you not aware? Are you aware that this might be a bias that you might have against religion or any cultural difference that you might have as a practitioner? And the way of teaching cultural competency or religious literacy, you can't learn all the religions. You can't learn every aspect of every religion or every culture. So I think that the key is communication, and the key is coming from a humanistic point of view. And like Dr. Stahl said, a communication and compassion. And so if we do communication, passion, and humanistic conversation with our patients, and we teach that in the dental schools and medical schools and all of the schools, we will actually be able to be better practitioners and better instructors and philosophers and everything. What we find a lot, especially in the Western world, is we find ethnocentrism. And what ethnocentrism is that it's the feeling that your culture or your religion or your point of view trumps everybody else's. And so when we're in a space of scientific evidence, and our culture here in the United States points us to scientific evidence, when people come with a religious background or a philosophical background, many people will tend to just not honor it, not even hear it, become confused with it, and discredit what the patient is actually saying. And so that opposite of the ethnocentrism is xenocentrism, and especially with a lot of disenfranchised communities who suffer xenocentrism, where they feel like other people's culture trumps theirs. And so they don't speak up. They don't ask questions. They just go with what the doctors might be telling them. And all of these things breed mistrust, they breed misinformation. And so as practitioners, the more that we can get in tune with our own bias, and the more that we can keep compassion and communication to the forefront, the better that we'll be able to serve our patients. And one of the ways we can do that is with cultural relativism. And cultural relativism will point us in the direction where we understand we have a bias. And just like the example that Dr. Stahl gave with the Jehovah's Witnesses and the lack of taking transfusions, we understand it, but we're able to accept it because we now know that people think a little bit differently than we do. And so I'm going to close by just talking about a few of my own patients. I have patients from all walks of life, and so many times I think to myself, why are they coming to me when they could go to their Buddhist and their Jewish and their holy? Why do they come to me? And I think that they do because we don't judge. We don't judge, and we also actually just listen. And so the communication of listening and asking the right questions so that patients can tell us things like, we don't like to take the blood transfusion. Or for me, it will be, I hear things like, a big one, which we're going to discuss later, is the vaccine. Why people don't want to take the vaccine. Why Muslim women only want to be seen by Muslim women doctors for the most part. And so as we go about this whole conversation today, I would like to ask each of us to just think about our own unconscious biases that we may have. I have to think about them all the time. I have patients that have tattoos from the top of their heads to the bottom of their toes, and they're afraid of a needle. And I just sit there and think to myself, you've been pricked and pricked and pricked, but you're definitely afraid of this anesthesia that you're going to get today. So without judgment, we just take a deep breath with no bias, with no judgment, and listen to their conversation. Because maybe at one point in life, they had a horrible experience, and that's where it's coming from, and not really the needle itself. So today I will be coming from, as we further our conversation, self-awareness and being taught in medical schools and all of the schools, taught about unconscious bias, taught about compassion, and taught about communication skills. Thank you, Heidi.
Thank you, Dr. Fanal. Dr. Edmod? You're still muted.
Can you hear me now? I said
Yes.
it was delightful, educational, and I learned an awful lot so far. But I come from a different background. I was raised in a Baha'i family, and learned early on respecting all faiths and actually being taught about different faiths. So growing up, I had a good understanding of Judaism, Christianity, Islam, and the Baha'i faith. And basically raised with an understanding that we are all the same. It's only one God. And then also was taught during my medical school training, and then based on my faith, that the science and religion, there should be some element of harmony between the two. You just cannot separate the science from religion and religion from science. So I really had hardly any difficulty in my practice. And I covered, I'm a trained child psychiatrist, board certified geriatric psychiatrist. I was the head of a neuropsychiatry at Penn, and then did research for about 20 years. So the widest spectrum of practices and encounter, I never really encountered any difficulty selecting or bias or having any misunderstanding about patients' point of view. See, spirituality and religion are two separate things. Spirituality is very individualized and has a very wide spectrum of understanding. Religion is more like an institutional thing. So when in my practice, when someone come in to see me, religion never really comes up. But there have been examples when the patient come in, if a Muslim woman come in and is covered, and I won't be able to see the face, I respectfully ask that unless I see your face, I will not really, in my profession as a psychiatrist, I really cannot make any assessment whether or not you're depressed, whether or not you're anxious. And I usually ask the husband to come in. And then if still the patient is uncomfortable, then I have to respectfully ask the patient, maybe you should see a woman psychiatrist where she's comfortable to basically be relatively unveiled so it can be attended more judiciously and properly. But outside of those very rare examples, really, religion never really come into my practice. And I don't think it really comes to physicians' practice. I think what you're really raising is also a fascinating thing. And that is, we need to raise our children early on in terms of understanding of human species and the differences of faith, and somehow help them not to be prejudiced against those who happen to have a different faith or different color or different shape or different background or nationality. That is really what is missing, not only in this country, I think is all over the world. So in so many ways, I was blessed being raised in that kind of a family, and I enjoy the practice that I did, and I'll be more than happy to entertain any question. One of the principles of the Baha'i faith is that if you're sick, you seek the best physician. That is part of the Baha'i text, that you seek the best there is in the illness that you are encountering and you're struggling with. And in so many ways, it kind of helped me to do the best I can in the kind of things that I am limited experience to do the best that I can for my patients. So I think I'm done, unless you have questions.
Thank you, Dr. Edmod, and thank you again for all three panelists. So that was wonderful. So we're going to start off the question section with a few prepared questions that the staff at the Dialogue Institute had come up with. And we also have a few SUSE alumni in participations here, and one will also ask a few questions he himself had prepared for us. So first question we have, and this is for all three panelists. What role do you think dialogue plays in how healthcare providers engage with their patients? Are these skills necessary for the patient-provider relationship?
I think dialogue is the essential in understanding, at least speaking from my own practice, understanding the patient and doing the best you can for your patient. Because I don't ever claim that I know unless I hear, and unless there's a dialogue established between me and the person that I care for. And through the dialogue process, I gain better insight and better understanding what the kind of thing that I'm going to be dealing with.
I think dialogue is critical, but I think it also must be taught with communication skills. Just having dialogue without communication skills and religious and cultural literacy can often be actually offensive to patients, colleagues, and so I just think that I agree that it needs to be taught. I do think that we also need to actually include those communication skills with the literacy of cultural competence and religious literacy along with it.
Yeah, I'll just sort of echo that. So I think in medical schools are fairly good at teaching students about shared decision-making, or at least the concept of shared decision-making as being sort of this two-way street where patients know a lot about themselves and their goals and their values, although not always. And sometimes you even need to guide them through those kinds of conversations. How do I connect my values with this particular medical option that I have? So that is being done, but I think sometimes, at least in my experience, the religious element or the cultural element can be a conversation stopper in that. So we're very comfortable talking about all sorts of values. I enjoy spending time with my grandchildren. I enjoy, these sorts of things. But as soon as somebody brings up sort of a very particular religious belief, that can kind of shut things down because it's hard to identify with that, perhaps. So I think that there is more work to be done in dialoguing in those more uncomfortable terrains. Those terrains can be uncomfortable for some physicians, either because of unconscious bias or just because they're not as informed about that religion as they feel like they might need to be. So that can kind of shut things down. So say the dialogue is so important, and a kind of humility about asking the right kinds of questions. I think cultural competency gets us close to this, or maybe you want to call it cultural humility, but I'm always trying to prompt physicians to, well, they said they want this miracle. Did you ask them what they meant by that? Did you probe a little bit further just into that belief itself? Because maybe they really wanted to explain it to you and you didn't sort of ask the follow-up questions that were necessary to understand. So I think that's where we can sort of push the dialogue forward.
Heidi, if you don't mind, if I could just jump in just to tease that out just a little bit. I'm curious for each of you if there are particular, I think Dr. Stahl kind of gave us some good examples, but just some specific maybe prompts or questions that you have found to be helpful at kind of opening up a conversation and creating that space for dialogue. Can any of you offer any kind of practical suggestions that have worked?
I think when you start, I'll start. I think that when we use our medical histories, we could do a better job with adding some of these kinds of questions to our medical histories so that we could actually get a sense of not just what medicines they take or allergies they have or past conditions they have, but if you notice that most medical histories have very limited emotional spiritual, when you see spiritual, it'll say, what religion? And it just kind of stops at that. And so if just like you probed us right now to look deeper into the question, I think that our medical histories is a good place to start the conversation with our patients. And if we are actually in an environment that we wish to make humanistic and have compassion, you can, just like Dr. Edmod said, I need to look at your face. You can look at people's facial expressions and their body movements and kind of get a feel to see if you're in tune, what else they may want to tell you. But I think the medical history form can be expanded and used as an initial tool to have those kinds of conversations.
You know, it's interesting. Every so often, I convey to my wife, I said, really, I think there was a miracle. And that refers to someone that I have been trying to attend, and the complexity of that individual psyche is so complex. And you know, it's interesting. Sometimes I kind of pray to be guided, to be put in the state of some tranquility or maybe reflective process to see whether or not I'm on the right track or be directed to the right track. Now, whether or not that really, that prayer to an unknown entity is assisting me, but it's certainly assisting me as an individual to kind of pause for a minute and to reflect. And I consider myself relatively a good psychiatrist after so many years. And then, so to be conscious of your own spirituality and your own faith and understand how delicate and sensitive and how important it is for you to have a faith and everybody else has a faith. I think it brings humility into your care of individual patients. So, I mean, I have seen miracles, but not that, but they're all medicine. I mean, it just happened that I figured that, you know, this combination or that combination, probably based on science, is the proper combination, and is all many times through the reflective process.
I'll just add quickly that I think there's some just sort of blanket questions that are always helpful. I'll caveat this with, I don't think that every patient wants to talk about their religion with their physician or any other medical professional, right? Sometimes that could just be like awkward and actually really uncomfortable. But if your choice is being directed by that religious belief and that's really obvious, or you're in an existential crisis because your illness has prompted you to re-examine your religion, I don't know why God would be doing this to me. I hear that sort of thing. You know, why is God testing me like this? What did I do wrong to deserve this illness? That really should prompt some questions. And I think questions like, can you tell me about your belief and why you're struggling so much? It sounds like religion is very important to you. Can you tell me more about that? Do you have a religious authority that you'd like to bring in that would be comforting to you in this moment? Might we send a chaplain your way? I mean, I think that just sort of probing into that a little bit more, and then learning from our patients when to stop. But actually, it seems to be that many more want to have those conversations that are being afforded the opportunity to have those. So when it seems appropriate, when the medical decision is being prompted by a religious belief, or when the patient is in a crisis, a spiritual crisis because of that religious belief, I think that's the appropriate time to start prodding them. To examine what's really going on and to figure out who is the most appropriate person to address those concerns.
But I think it's an excellent point, but at the same time, I never forget a family who lost their son, and they became so angry at their own fate. And they basically said, I don't no longer believe in God, and so forth and so on and so on. And I happened to be involved with that family, and I tried to basically help them to understand that the mishap and unfortunate events happening to our loved one has nothing to do with God. It's just a bad accident. Try to help them that they can refer back to their own faith, talk to their counselors, speak to their ministers or to imam and so forth. Try to understand that really that God has no place in these things. See, one of the challenge in medicine is the patient coming to you. On one hand, they believe that God really has the ultimate decision in terms of your life or not living. And at the same time, they come to you as a physician, expecting that you, with your knowledge, has that tool to rescue them from that illness. So the patient has struggled that to begin with. 60, 70% of the patient, according to statistics, they really believe in faith, in God, that God ultimately decides about their life. And then how do you plug in as a scientist into that scenario to assist your patient so they can still remain faithful and at the same time to be compliant with the scientific thinking?
Thank you. I see that we have already some great questions in the chat. We'll get to them shortly. We would like to invite now SUSE alumni Manuel to ask one of his prepared questions.
Hello, I'm Manuel Maroon, a fifth-year medical student from Lebanon, and I'm glad to be here with you tonight. I just wanted to ask if any of the panelists ever witnessed any sort of miracles. Sometimes, if so, how can they explain them? And the results are quite surprising when it comes to the CT scans, the MRIs, something that we can really evaluate. So what do you think about this, and how can you evaluate them?
Is that question directed at me?
It's directed at all three.
Oh, what was the question again? I missed the first part.
If you can evaluate, maybe not in your domain, for example, not in psychiatry, but for example, if a miracle happened in neurosurgery or in any other medical domain, how can you explain this, especially when it comes to results that you can really see, like in the MRI, CT scans, everything, sometimes in X-ray? How can you explain miracles if you are a physician, if you are a nurse, if you are in the medical field?
Well, I can speak on the fact that although we know an awful lot, but there is also an awful lot which is unknown to medicine and to science. So things changes and we don't understand it. Patient comes and says, I'm fine, I got better. And in many ways, it is truly a miracle. But at the same time, we know that there is so many unknown in terms of science that can happen without you knowing it. Now, it's my take on it.
I agree. The way I explain miracles is the same way. Is that there's so much we don't know. We know so really little about the human body. And much of what we know are theories that we have all kind of accepted. And then as we move on and move on and on and on through evolution, one might say, things that will kind of reveal themselves later on down in history, and we'll think that, oh, it's so interesting. They thought that that was a miracle years ago. And so once our country separated state and religion, we sort of, became and have a disconnect. And staying non-judgmental about whatever the patient believes has happened is probably a good way of just honoring their beliefs, and also honoring our scientific evidence-based knowledge.
Yeah, I don't know that those things have to be in contradiction, right? So, and I think that's what Dr. Fanal, you're saying. I mean, the more I do research on miracles and how patients believe in miracles, the more I realize that we all actually are saying something really different. And so I never presume that we all have the same definition of miracle. Even in the Christian faith that I belong to, people can think miracle means either some completely unexplainable event, something that doesn't really happen anymore, or it can be the mundane things that are extraordinary. Every child is a miracle. So the ways that we use those terms are just so varied. And so it's good to probe into what the patient really means by that. But I mean, I think a lot of physicians, even if they don't necessarily adhere to a religious faith, would admit that there are things they can't explain, and they're perfectly happy to let the patient sort of say that it felt like a miracle. I think where it gets tricky is when patients are sort of then driving medical decisions based on that hope for a miracle to occur. And so that can create some sticky situations where the physicians feel uncomfortable providing certain treatments. But I think it's the last Pew study I looked at in 2015 said something like 80% of Americans believe in miracles. And the majority of them believe that a miracle can happen and save a patient's life, even if the physician says that they're certain to die. It's something like 60% of people believe that statement to be true. That's an incredible number of people who will not trust physicians, like sort of prognosis that death is certain. And so when we sort of take that into account, I think we really need to be careful then how we're talking about what the miracle is and what we should expect from that, given how many people continue to believe in the presence of miracles in medicine.
The next question we had for our panelists is regarding medical schools when you attended medical schools and medical schools today. We were wondering if religious literacy is taught in medical schools, and if so, in what capacity? And if not, do you believe that it should be? Do you feel that the education that you received when you were in school prepared you to properly treat patients with diverse religious backgrounds?
I can go first this time with that. I think it has really grown, and it's not like it was when I went to dental school 25 years ago. You'll see a lot of our major institutions. So for instance, in dentistry, we have CODA, the Commission on Dental Accreditation for dental schools. They have actually put cultural competency, of which religious literacy falls under that topic, as a prerequisite to accreditation. So dental schools have to prove that they are teaching these things in an experiential way, as well as a didactic way, to their students. And because of that, and also because of the diversity that we see in the dental schools around the country. Some places are not diverse at all, and some places are really very diverse. But because of the diversity and all of the social media and communication methods that have made us global, we all, even though we oftentimes feel comfortable in our own microcosm of where we are, we've had to expand our thinking. And so since we have become global like this, we have thoughts and philosophies and education from all over the world now coming together in our schools. And that has provided a wonderful dialogue within the dental schools. So the medical schools, I'll let the doctors speak on those.
I do know some of the medical schools in this country do have, as part of the curriculum for the medical students, some insight into religious diversity and faith. How much you need? It's a good question. Did I have it when I went to medical school? Yes. And then I think what really helped me a great deal was my upbringing. And I think that is what is missing really. I mean, again, I don't mean to be critical, but having my children born here, raised here, went to school here, associated with so many other families and so forth. Faith always has been kind of in a back burner, and to some extent, insensitivity to diversity has been always in a back burner. And so I think these are the kind of things that we can do when we contemplate to have family and children, and educating our teachers and helping parents and so forth to really raise community with sensitivity about this diversity and understanding about differences. But I think we're on the right track. I think we're going to get better as we dialogue more and more. I think future is bright. And
So I've only ever worked in one medical school, and the entirety of that medical literacy or the religious literacy training was a lecture that was mandatory, and all the students really resented having to go to because of where it was placed in the curriculum. I think it's true, as Dr. Fanal just described with dental school, that there is a cultural competency element that is needed, and religious literacy would fall under that. The tricky part is kind of like with ethics as well. You just have to show that you taught it somewhere, and it doesn't, there's no requirements for like what you have to teach or how it's being taught or how many hours it's required. So you can get incredible diversity in what students are being taught across medical schools. I know some medical schools have really robust religious literacy programs, and some have almost none. And so I think that some consistency across accrediting boards so that the ACGME would be nice. But I also think it's really tricky, like who's competent to teach that and how is it being taught needs to be standardized. Because I'm afraid that what a lot of students are getting is just not good enough, or actually might be detrimental to what I'm sure everyone's seen these, like some of these medical textbooks that are like, Muslims believe this and Christians believe this, and that's just not a very good way to be taught about religious literacy.
If I can just jump in for a moment, I think it was Dr. Stahl who made the comment that having some religious literacy knowledge can be dangerous. Like you can have just enough to be dangerous, and to perhaps maybe bring more obscurity to the conversation with the patient rather than clarity. It reminds me of what Dr. Edmod said about this distinction that you made between religion and spirituality, of saying that, yes, we're rooted, in a religious or non-religious tradition, but that sense of spirituality is something that's very much the driving force to the person that is in that room with you. And they may be Muslim, Hindu, atheist, whatever it might be, but what are their spiritual needs perhaps in that space, in that encounter? And I think what you've all been saying is, thinking through like, what are the right questions to ask for that moment? Is this factor, does it need to be brought into this room? Is the patient bringing this forward as something that needs to be addressed? but dialogue blended in with religious literacy and really focusing on the person there rather than the representative of some larger imagined group is probably a good approach. So Heidi, could you maybe turn us to one of the questions in the chat?
Sure. The first question we had posted in the chat was from Effion, and this was directed to Dr. Fanal. He stated he was wondering whether virtues such as compassion, patience, kindness, etc., and striving to promote the dignity of individuals can as well be cultivated by medicine. This was very early on when you were speaking about dialogue and medicine.
Yes, I think it can be cultivated in medicine. And yes, I think it should be cultivated in medicine. And the reason why I think so is because those attributes are what connect us as humans. And so when we talk about religious literacy, there's a humanness underneath all of that. And if we can just tune into the humanity aspect of it, then the religious literacy becomes, it can become helpful, but it's not the all in all. Because when you're looking at a person, you're seeing human. And we all say that all the time, you know, oh, we're all human, we're all human. But a lot of times we don't really treat each other with that golden rule, do unto others as you would have them do unto you. And doctors, I mean, patients ask me all the time, would you prescribe this to your mother? And so, you know, when they ask me that, you know, it always jokes me because yes, I would. This is why I'm giving you this recommendation, because I'm treating you as a human being just like I would treat my own mother. And so in our society where healthcare has become so monetized or economically based or all of those financial words. And so we have students who come out of medical school with increasing debt. And so the ethics and integrity comes into place where they're trying to pay their school loans. They're still trying to drive that car. They want to get married, the big wedding, the da-da-da-da-da-da-da-da. And so for surgeons, for internists, it doesn't really matter. If we don't teach these things early on, compassion, other things can lead us down a path where we're not actually honoring our patients and we're honoring financial gain. I'll just use those kinds of words. So yes, I do believe that compassion, kindness, respect, like Dr. Edmod said, just respect will go a long way in the I was going to say dental education, but in the medical education as a whole.
You know, I'm so delighted to hear what you said. These are the attributes that we need to teach, not just at medical school or dental school. We need to teach them at home, in primary school, in high school, in churches, in the mosque, in synagogues, on the streets, everywhere. We need to create a culture of understanding, sensitivity, compassion, decency, and honesty all along. You cannot cramp humanity into complicated, packed curriculum of medical school or dental school or nursing school. As it was stated, you give a course, nobody wants to hear it, they hate it, 1 hour, 2 hours, get over it and out. You see, it's not going to have any impact unless we learn, begin early, so we create a society where sensitivity and understanding and decency becomes part of the makeup. Of course, that's my point of view.
Thank you. We had one more question from Manuel. He wanted to know that when the cons outweigh the pros in any given treatment, like in palliative care or during final stages of cancer, do doctors still have a moral obligation to continue treatment, or can they place the patient in hospice care and make them as comfortable as possible until they pass?
I can start on this one. This is really tricky. So the first thing I'll say is, as a clinical ethicist, I'm always trying to prompt physicians that they absolutely shouldn't be providing treatments that they don't believe will work. And you might be surprised how often I have to reiterate that, because a lot of physicians are under the impression that if a patient insists or asks for something, then we're obligated to provide it because that's what they want, and it's all about patient autonomy. But of course, if it's not going to benefit them, it's probably going to hurt them. And so we ought not to be hurting our patients. We can't, in this country, automatically enroll them in hospice. You have to actually agree to be in hospice. So we do want to make sure that people are consenting to things like hospice care, even though I think it's an incredibly wonderful program. If you don't want to be in it, then we can't force you. But we also, you have a right to reject any and all medical treatment that you don't want, but you do not have a right to request treatment that physicians don't believe will benefit you. So that's sort of the big difference. So we don't have to provide things that won't work, but we're not going to then force you into hospice. We can sort of guide you into comfort care. But these are things that you need to also agree to. So we need to be careful in that balance.
Can I just piggyback on what Dr. Stahl said? And I'm going to just go back to what I just talked about a little bit earlier, and what Dr. Edmod said also, it's a wider picture. It's not just medical and dental school. It's pharmaceuticals, it's insurance companies. Many times these doctors get caught up in standards of care where they don't want to be sued, so they're trying to do things that, their integrity tells them to go one way, but the insurance company tells them to go another way. So this whole concept, like Dr. Edmod said, has to be overarching. It's an overarching concept of bringing integrity, and I don't even want to say integrity, but holistic care. I'll call it holistic care, where we are caring for a patient's mind, spirit, and their soul. And so in our country, we tend to be, because we're so scientifically evidence-based, we care for the body. And that's what we do. And we leave the emotions to the psychiatric people, and we leave the soul to the spiritual people or the religious people, whatever you would like to say. When we can find a way to blend all of those back together and treat our patients holistically, mind, body, and spirit, then I think that, and I'm going to even make it broader to say we treat them environmentally too. Like some of our environments are really not healthy for patients. And when patients ask me, what's the best treatment? Well, the best treatment for you may not be the best treatment for somebody else. It's also quite individualized. And so we've all seen where people on drugs, for instance, substance abusers, they go right back into the same environment, and it's very hard for them to make a way. And so when we can incorporate these three modalities together, I think we're going to see a a real change in how we approach medicine. I hope that wasn't too wordy. You understood what I was saying.
We would now like to open it up to the rest of the participants. If anyone has any questions for our panelists.
If you already asked a question in the chat, don't be shy. You can go ahead and, I think Heidi, it's okay if they unmute themselves. Would that be all right?
Of course.
Thank you. May I?
Go ahead.
Yeah. Thank you for all the speakers. I'm Jekonia Tarigan from Indonesia, Yogyakarta, Indonesia. I'm doing my PhD now in Indonesian Consortium for Religious Studies, Gajah Mada University Graduate School. I'm really excited to discuss because I am doing my dissertation research now about the interreligious encounter within religiously affiliated hospital. So maybe I need to tell the context first. In Yogyakarta, in my city, there are 3 religiously affiliated hospitals from Christian, Catholic, and Islam. All of them already serve the society like for hundreds of years, and people go to those 3 hospitals no matter what their religious background is. But uniquely, interestingly, majority people in the city are Muslim, and most of them go to Christian and Catholic hospital. So yeah, I found it is interesting that in Yogyakarta, the problem of religious identity is quite strong, actually. I mean, like, yeah, some people from Muslim side actually quite sensitive about Christian mission. So even they go to the Christian or Catholic hospital, but there is an like accusation whether they will be asked to be converted to other religion, to Christian, for example. And yeah, they still enjoy the medical service because most of my informant, for example, they said that Christian hospital provide better service than Islamic hospital, but still those accusations exist. Even they like differentiate. I mean, they can go to Christian or Catholic hospital, but for another issue related to some doctrine, for example, they are forbidden to wish Christian Christmas, Merry Christmas. So it's like different field, different cases related to certain religious doctrine. They cannot accept it. They cannot do dialogue with Christian. But in the healthcare context, they go to Christian hospital because they need it. Like Dr. Edmod said that when people get sick, they search for the best service. So how actually my question specifically go to Dr. Stoll. How do we see dialogue in this kind of context? Because in hospital, mostly people accept the issue of religion in universal way, I think. So if the healthcare service or the counselor from the hospital come, they may accept universal message. Yeah, keep spirit and be disciplined to use your medicine, something like that. But if it is already go to the specific issue of religion, they cannot accept it because it is rather sensitive. But if the people, because Yogyakarta most of people, some people also come from Javanese ethnic group, and they usually accept like interfaith marriage. Some of them also accept it. How do you see, like, I mean, the religious background, the experience of interfaith in their own family also influence them in accept the dialogue within religiously affiliated hospital? Maybe my question and the context is rather confusing, but I'm really excited to hear from you, Dr. Stoll. Thank you.
Sure, yeah. So it's a very different context than what I'm used to. So the first thing I want to say is like knowing your community is so important to resolving these issues. So I'd hate to sort of like tell your community how they should be thinking about this because it's not my community. So I'll risk some humility here. But I do think there are some tactics of being open and trying not to be so judgmental that hopefully can prompt conversation. I would never push somebody to start talking about their religion if that made them uncomfortable. At the same time, so when I was trained as a chaplain here in the US, it was very important to be a interreligious chaplain. So even though I come from a specific tradition, it's never my goal to impose that on anybody or even to sort of try to manipulate everything into like a Christian conversation, which required me asking a lot of questions of people and assuring them that my goal was not to convert, was not to force a religious conversation, but really my goal as the chaplain was to just comfort them and be there for them and talk about whatever it is that they wanted to talk about. And at first, some people would be very sensitive about religion and not want to talk about it. But the more they saw that you were just there to have a conversation, to talk about whatever it is that they needed to talk about, the more open they would become. And as a young female chaplain, you know, some people were very suspicious of me, that I didn't have the kind of religious authority that they thought was important. And so they rejected me sometimes, but sometimes once they saw that I was open, they were more open to me. So I think just being gentle and guiding in those ways, being non-judgmental, as our other panelists have said, and sort of exploring with them what interfaith means, making sure that you come across as a person who's not trying to convert them. I think those can be strategies for opening up conversation, but I think also like knowing the context of your situation is so important. So for me, getting to know the religious authorities in my community is really important for the work that I do. Getting to know how they talk to their parishioners, very important. And so the more I can do that, the more I can loop them into conversations and the more I can sort of understand my own community.
Thank you, Dr. Stoll.
Thank you. In the chat, we had a question from Sergio. Sergio, would you like to ask your question now?
Sure, let me go back and read it again. Where is it? So in hospitals, in the experience of the people, of the three speakers, is there a systematic approach to involving hospital chaplains in difficult situations that require cultural and religious competency?
I can speak for University of Pennsylvania, and the answer is yes. And they're always involved and very helpful. And
that determination is just made by the healthcare provider to say that there would, you know, they just have a sense of like there needs to be some more insight brought in, or how are those decisions made?
well, there is a healthcare provider. I think your there's an echo. There's a healthcare provider primarily, and then a consultation with other healthcare provider in the setting and their staff. And then collectively, it's an understanding that we need other services and other experts into the mix, especially the chaplain, to really give us a different insight, different point of view to deal with this complex issue regarding the individual health issue or families issue and that kind of a scenario. Pretty often. And I have been involved with a number of them.
I would like to also chime in and piggyback on Dr. Edmod. In my years of nursing as a registered nurse, when we have team meetings, the recommendations can come from any point on the patient's care, at any point on the patient's care team. So the recommendation can come from the nurse, it can come from the doctor, it can come from the social worker, whoever had a interaction with the patient and said to the team, okay, we need to bring in a chaplain, or we need to refer the patient to a psychiatrist. So those, anyone on the team, and I want to say that the hospitals that I worked in all had a way of putting that information into the system so that it got done.
So that's my experience too. So any member of the healthcare team can make a referral, which will go straight to the chaplain, either through a consult request or through the medical record. Patients themselves can typically request a chaplain, although most patients don't know that chaplains exist, which I think is so strange. But and in part because most hospitals that I've ever worked in have like a 1:100 ratio of chaplains to patient beds. So in a hospital of about 400 beds, my hospital has 3, sometimes 4 chaplains. So there's definitely not enough chaplains in hospitals. And when healthcare jobs are getting cut, it's typically the chaplains that get cut first. So we have this sort of huge problem, I think, of a lack of chaplaincy, but the mechanism is typically there. How many patients chaplains are able to see in a day just might depend on the capacity of that particular hospital and how many chaplain staff they have. And if they can cover nights and weekends, because not all hospitals have chaplains that cover nights and weekends either.
I just
a
want
lot
to,
has to do with the diagnosis of the patient. Would you agree, Dr. Stahl, Dr. Edmod? Patients who have a more severe diagnosis tend to get into that system a little quicker than patients who have less severe diagnosis.
Yes, it is. And I think the patient even is, have the right to ask for their own chaplain or their rabbi or imam or their religious leader or individual that they can trust to be part of the team and consult with or comfort the patient and so forth. It's a pretty kind of an open door process to assist the family and patients to go through that difficult time.
Sorry, the palliative care team at our hospital itself has its own chaplain. So those patients that are sort of are chronically ill and tend to be a little bit sort of getting a little bit more serious, there's a chaplain that works just with them. That's not true of every hospital, but I do think you're right, Dr. Fanal, that the more serious your condition, the more likely it is that the healthcare team is going to recommend that you speak with a chaplain. But I think anyone at any point can request that in the hospital.
Can I just chime in? I'm a healthcare chaplain. I actually have some patients I have to go to see, but you're right. Thank you, Dr. Stahl, for speaking for chaplains. I put that in the chat. And to Jaconia's question, which I thought was great, I think that even though we don't often work in that environment, the people that he was talking about, it sounds like it's the healthcare facility that projects a specific religious ideology that that the patients are concerned are going to be projected onto them, or forcing them to convert. That does happen in small bits here, because very often there are staff sometimes that or people that come from outside who have not been trained as you were, Dr. Stahl, or that I was. I'm a board certified chaplain. And so they feel it is their duty to convert. And we try to avoid that. And even here, we have people who don't want to see a chaplain because they're afraid that they're going to be, they're going to proselytize. So that does happen in certain instances. But again, I think that that's a whole nother question. And and the other thing, in terms of what you were just speaking about, I'm glad I put that question in the chat, that, how often do medical professionals use the chaplain? So I'm glad to hear that it sounds like you all do in certain instances. And again, to your point, yes, I've been more of my time as a chaplain has been in hospice and in palliative care. And when a person gets to that point where their diagnosis or prognosis is more severe, then people feel that, well, this is the time, but that's when medical staff is backing off. And so the end of life care goes to the spiritual care providers. But most of us who do this work think that it should come in a lot earlier. And because it's not about, it's a lot of what we do is listen. We listen based on the person's spiritual trajectory, based on the person's spiritual background, not on what we believe. But a lot of people do feel, even here, that the reason why a chaplain is coming into the room, sometimes I have to say, I'm not here because I think you're dying. So yeah, there's this perception, and part of what we can all do is to clarify that for people, to have them feel more comfortable visiting with a spiritual care provider, as we're often called now, as opposed to chaplains, to kind of break that barrier again between religion and spirituality, etc. So thank you very much for a great conversation.
Before we end for today, Giddy had something to share as well.
Do you? Okay, maybe.
1 second.
Yeah.
Since you're both in the same setting, go ahead, Giddy.
Is it okay now?
Yep.
I think still. We can come there. Yeah. Nobody can.
While Giddy transitions over to the other computer, just a reminder that Sage will be submitting this video to YouTube. It will be posted and made available on YouTube very soon. And we'll be sure to send that link to you all in case you had to miss part of the conversation. There's so much rich dialogue and conversation. I for one, want to go back and listen to it again myself. So we'll make that available to you. And also, before we turn to Giddy as well, please do visit our website. And I'm wondering if Sage, if you wouldn't mind popping the link to our upcoming events in the chat just one last time. We have some excellent events upcoming on talking about religious pluralism and education curriculum around the world. And then we'll have a digital tour version of our religious pluralism tour of Old City, Philadelphia will be coming up in December, and a couple of other events to be determined. So please do keep in touch with our events, and we'll make sure you're on our email list as well. So Giddy, do you have some final remarks?
Yeah, no, I just wanted to make two short comments about what we talked about before. The Yale University School of Medicine, in their Department of Family Medicine, in the questionnaire that they ask the patient on arrival, they ask, do you believe in God? If they say no, they just let it go. If they say yes, then they go a little bit further and they say, do you go to any church? And if they say no, then they say, okay. Then they go further down. The reason they do this, they want to find out if the physician can get any, in the case of need, they can have some help from the family, from the church, from the community that would help the family. So I think this is something that Yale University Medical School has started. The other point I want to make, it came about the chaplain, is that I work at St. Christopher's hospital for children. And because in the Baha'i faith, we don't have a clergy, it was a very sick child, and they were wondering if there is no one around, what they can do. And I said, I leave you a Baha'i prayer. Whoever wants to read it to calm the child or calm the family, that would be good. So there are books from different faiths. At least it was when I was there. I don't know, it's still there. So that's another way to give some spiritual support to the patient or to the child who is very sick.
Thank you, Giddy. And thank you everyone for joining us today for this very important dialogue. Obviously, there's so much more we could say on the topic, but we are getting close to the end. Just wanted to remind everyone that this video will be posted on our YouTube channel, and Sage put the link in the chat. So you could go back and rewatch it or send it to anyone who couldn't join us today. Sage also said that she was going to save the wonderful conversation we had, the chat, for you as well.
So are we finishing, or can I just add one last question that has been on my
Last
mind?
word.
Yeah, I'm sorry, but I just need to ask this. Okay, so now we touched on the level of respecting religions and having dialogue and all that. But if let me say if we put people in categories, just for the sake of this question. So we have the people who are being treated and they don't care so much about religion, and that's not a problem for us. And then you have this group of people who are religious, but you as a healthcare provider has to accommodate to their beliefs. Let's not say religious beliefs, but their beliefs, and that can be solved. And then you have this group that their beliefs can affect their health, but only affect their health. Like Renee said, the woman who doesn't accept to have a blood transfusion, and that's okay, because at the end it's her decision. But I want to ask, what if his decision or his beliefs could affect someone else's? Like, for example, here in Egypt, I graduated from medical school last year, and I am working now in general surgery. And in Egypt here, we have a problem with FGM, or female genital mutilation, or the what they call female circumcision. And this is a huge problem here in Egypt. And people, and this problem, or people say that their beliefs, this is their beliefs, but actually it's affecting their children, or young girls who don't have the authority of them or over themselves at this age. So don't you think that me as a healthcare provider should have some authority when it comes to such things? Because now we are surpassed this problem of my beliefs affecting me. So it's my life. Now we have gone so far with this. So what do you think about this problem? How can this be addressed? Because believe it or not, it's still happening. And some people say it's religious, but I don't know. Let's not say it's religious. Let's say it's just beliefs, cultural beliefs, whatever it is. But it's still a problem, and it still has to be addressed, because it is affecting so many lives around the world. And I have seen it myself, and it's very devastating, and it breaks hearts. So how can you think we can address this problem? Thank you very much. And I'm sorry for taking so much of your time.
I think we as a physician have sworn not to do harm to patients. And that is our moral, ethical, legal, spiritual obligation to do whatever we can to fight this awful, almost like a genocide. I mean, I have been involved in, some legal cases, people from different countries, mostly European and so forth. And I think we as a physician has that obligation to really rally around this issue and get it to stop it. it's, say something, do something. That's my statement.
Yeah, I'll just quickly add that in this country, we don't let parents make decisions for their children that are potentially life-threatening or mutilating. So it's not as much of an issue in our country because the Supreme Court decided a long time ago that we can't make martyrs of our children. And that's sort of the famous line in the case. So there's lots of instances in which physicians are able to override parents who are making life-limiting decisions for their children based on any number of beliefs, but also that all clinicians have a right of conscience themselves. And so if a patient is requesting something for themselves or on behalf of their children that the physician thinks is immoral or wrong, they're allowed to say, no, I don't want to participate in that. It's my right of conscience to say no. And we respect that for the most part in this country, especially with these kinds of cases where there is considerable dispute about whether this is part of the medical profession or not.
Can I just answer real quickly, piggybacking off of my co-panelists? Never underestimate your power of education. And you might not use your power of education within the actual hospital setting, but outside the setting, you and other physicians can go around and just teach people. We were really effective. I worked with a group that went to Latar in Africa, in Ghana. And in Ghana, there was a real problem of this cultural taboo that they would be cured from AIDS if they had sex with a virgin. And so the men in the community were running around, attacking the virgins to try to get cured with AIDS. And so what we did, I didn't do it personally, but I did contribute money to the cause. But what they did was they actually wrote up a whole curriculum of education to teach not only the men in the community, but the women in the community, the mothers in the community, and also the boys and the young women. And they had the statistics of they really did make a difference. So you do have that power of education that you can get with your colleagues and make a difference in your community.
Thank you so much for that. And thank you, Moman, for taking the risk of asking one of the most difficult questions of the conversation today, right at the very, very end. But I'm so grateful that you all stayed around for that, because that was really a powerful call. And there are so many issues and topics that emerge out of our conversation today. We could have a series of these conversations or perhaps a conference someday. But thank you all again, much, much appreciated. And let's stay in dialogue, and you'll see this video will be posted soon. So thank you all for joining us from around the world.
Thank you. It was a pleasure.
Thanks, everyone.
Thank you.
Thank you.
Have a good day, guys. Thanks for joining.